Welcome to our conversation around pediatric mental health. We're talking about something that's been defined as a national crisis. Last year, the Children's Hospital of Colorado declared a state of emergency for youth, and it really was around mental health issues and the huge volume that we're all seeing in our pediatric hospitals. I'm so excited to be joined by this very esteemed panel of experts, and we've all worked together for a long time, and mental health has been an issue that we've all addressed and all wanted to address for quite a long time. So I want to thank Health South Connect for giving us the opportunity to have this conversation today. I think this is an issue that touches everybody. 1 in 5 children have some form of a mental health issue out there. 50% of all mental health begins in childhood. We've seen a massive increase, 24% increase in emergency room visits for children 5 to 11, a 31% increase in ages 12 to 17. These numbers are staggering, and these are our kids. So I appreciate everybody taking some time to talk about this today. Lisa, why don't we start with you? Why don't you give us a little bit of overview on what you're seeing up there in Tennessee and what the volumes look like and what you're dealing with up there?
Sure. Thanks, Dawn. Glad to be here today to have a conversation about this, as you said, national crisis in behavioral health issues in kids. And so in the state of Tennessee, we started looking at numbers probably about 4 or 5 years ago in conjunction with the Tennessee Hospital Association and on the adult side. And we knew there were issues, we knew there were challenges, but I don't think anyone quite understood what was going on from the state overall. And so once we started pulling data and really talking between hospitals, we really got information. And just like you said, this really is a crisis. And it's a crisis not only in the state of Tennessee, but all throughout the country, with children being caught up and being a part of behavioral health issues. And so, really, we recognize this as acute care hospitals that we're the tip of the spear, because unfortunately, this is where children land when there's breaks in the system. And we learned that early on as our emergency departments became inundated with children who did not have medical conditions, but who unfortunately had behavioral health conditions. And so we started looking at data throughout the state of just how many kids we're holding in our emergency departments, how many kids were waiting on either inpatient psychiatric beds or some form of counseling and intervention that would get them back into their communities and back in school, back interacting with other kids. And what we found really was that we were all facing the same thing throughout the state. We have pockets and still continue to have pockets of great work that's being done, but unfortunately, we also see many, many children who are sitting in our emergency departments just waiting on psychiatric services. So today, I have an 86-bed children's hospital in the northeast part of Tennessee, and I have nine behavioral health patients who have no medical conditions today, just waiting on some sort of placement or some sort of intervention to get them back into the community. And so it's all relative, all throughout the state. In every hospital, there are patients in need of psychiatric services that are in, unfortunately, acute care environments waiting on that service.
Wow, that's really unbelievable. 9 children with mental health issues just hanging out in your emergency room because there's no other place for them to go. Dr. Gilmore, thank you for joining us today. Some of what Lisa's talking about here is shocking to many of us that don't, people that don't work inside children's hospitals. They're thinking, why are 9 children having, what kind of kids are in there? What are the behavioral health issues they're having? Maybe just take a second and talk about, some of the mental health illnesses that are out there, what you're seeing in your emergency room, maybe the ages of these kids, maybe, the types of disorders they're dealing with, and really kind of make it personal for people.
Sure. Well, glad and thanks for inviting me. This is a subject that we've been dealing with for obviously all of us for a number of years, not just with COVID, although there have been a lot of I think increased stressors that are exacerbating this problem with the pandemic. So for us, we're in West Tennessee, with that in Memphis. So I have a 255-bed hospital with that, a very busy emergency department. Over 100,000 just children come through that emergency department every year with that. over the years, what we've seen is an increasing number of children who would present with a spectrum of behavioral problems with that. Some of the more obvious ones would be in our teenage years with our suicide attempts with that. But we have also noticed over the last 5 to 7 years that the suicide attempts have increasingly reached younger age children. So we will now see children who will present for evaluation or treatment. A lot of times they come for treatment of their attempts down into the elementary age children with that. So a big change from that before, when you see a 10-year-old or even sometimes an 8-year-old that has actively tried to end their life because of issues that are occurring either at home, at school, or in general with those types of things. Those numbers are regular for us at any one time. Lisa mentioned the number that are holding, but any one time on a daily basis, we're holding at least 2 to 3 behavioral health kids in our emergency department, and then on the floors we may have anywhere from 3 to 7 or more that actively have suicidal ideation. And whereas we do not have psychiatric facilities and treatment within our hospital, as many children's hospitals have found across the country, with that, we end up being the place where those children are housed because of a lack of resources in the community. So, for example, some of the kids that are coming in with this, for our teenagers, we see typically a bounce up when school starts at the first of the year with that. And then we also see a secondary peak that comes when after Christmas or Christmas break, and they come back in again with that. Tends to taper off during the holidays and also lowers down when they are out of school with that during the summer with that. So the stressors that occur with that, I think there are 2 edges there. What we've noticed with the pandemic more recently is that although we see that there's an increase in stressors for children when they are in school, especially when they first start, this past couple of years with the pandemic, with them being out of school and without their support system with that, we've seen those numbers rise dramatically. And I believe Don has just mentioned some of those. But, you know, the Journal of Pediatrics just did a pooled study with that where they showed clinically elevated depression in children across the board up 25%, and adolescents up 30% with that. So we can see that our kids are suffering even more than before with that.
You know, it's shocking as the CEO of a children's hospital to have to learn that, you know, kids that are having suicidal ideations or trying to commit suicide as young as 10, you can't document a suicide in a 10-year-old unless there's a note. And it's amazing that a 10-year-old could kill themselves, and to have to see this, it's terrible. So when we're talking about mental health, a lot of it's suicidal ideations. There are a lot of other things that will affect kids and then really turn into adult problems later on. Gabe, I am so excited to have you join our panel. Everybody might be saying, what is a commissioner of Medicaid or a former commissioner of Medicaid doing with a bunch of people talking about suicide and kids and mental health? But you were really a partner for us in Tennessee. You partnered with the Children's Hospital Association of Tennessee to help create solutions. You know, talk a little bit about the process we followed, you know, what your thoughts were, you know, how did you help convene people? I mean, you know, 50% of the kids we take care of in children's hospitals are Medicaid, and to have the head of Medicaid that involved, I think is a very unique thing. So I'd love to hear a little bit more about your experience.
Thanks, Don. And I would like to thank Health Connect South for having me on the panel as well. And you're right, I'm the least qualified and least important person on this panel because unlike my colleagues, Lisa and Dr. Gilmore and you, I haven't actually been on the tip of the spear and actually there trying to meet this issue. But I think I do have a unique perspective of it. You know, TennCares is what we call the Medicaid agency in Tennessee. It has been around for nearly 30 years in its current form. It's had multiple iterations. But, you know, about 15 or so years ago, one of the really, I think, one of the kind of the sentinel reforms or evolutions in the Medicaid program in Tennessee was that we integrated and put a big focus on physical and behavioral health. And that was for all of our population, children to adults. And I think that was really important because I think my predecessors and a lot of the policy folks in Tennessee at the time realized that there really is a need for holistic care. You can't separate behavioral health and physical health. It just isn't really possible. And so I think a lot of work was done that I was able to learn from and kind of be the beneficiary of in some extent. But to your point, Don, when I came into the director role from a previous role, I too was shocked when I heard some of the statistics that both Lisa and Dr. Gilmore and you have shared. They were a little bit different at the time. This is several years ago, but I was shocked. I was shocked that our system seemed to have, as good as it was, there seemed to be some gaps there. It seemed really troubling to me and concerning to me that there were children that had no other place to go but the pediatric ED. I thought that was really difficult. And I thought we could do better. And so what I was able to do was just frankly be able to convene folks, have conversations, understand what you all were doing on the tip of the spear, on the ground, what you were seeing, and be able to take that back to our team and try to figure out, well, what can we do to address these issues? We had started a few years before I got into the role, a really large value-based, outcomes-based program in Tennessee Medicaid. We were really trying to reward and incentivize behavioral health providers and physical health providers to work together. And one of the things we found when we pulled a lot of folks together was, number one, there unfortunately wasn't the level of transparency and data sharing back and forth that we needed. Number two, there were some systemic issues that caused that, not the least of which is that IT tends to be really expensive. And in order to be able to get folks to be able to be on the same page and speak in kind of the same code language, there was a pretty big investment that needed to happen up front. And then number three, despite the fact that we had been a physical and behavioral health integration program for a little over a decade, there were still a lot of handoffs that weren't happening quite well. And so what we had embarked upon, along with the MCOs in Tennessee and the providers, was to be able to start upfront providing some kind of cost subsidies to help get everybody on the same space from a coding and diagnostic level, and then also be able to build some infrastructure, especially with our hospitals, being able to get ADT data, admissions, discharge, and transfer data, and get those into the hands of the behavioral health providers out in the community and the physical health providers out in the community. And we had begun to start seeing some pretty impressive results from that work. But what you all with chat told me was that we still had a lot of work to do in the children's side. I wish I could be able to tell you that we were able to find the gold standard of that, and that all of these issues we're talking about right now were just COVID related, that we had solved the underlying problems in the system. We haven't, but I think we had some really important conversations that went a long way in helping us be able to set the stage for working better together, understanding what some of the issues were, and really trying to put both some budgetary kind of priority from the state agency level behind trying to find some of these solutions, and also awareness on some of the policymakers and legislators and governor's office about how difficult this situation really is. Now, it's not up to me to say whether that was actually helpful or not. I think you all would probably be better than I would be at that. But I do know that the team at the Medicaid agency in Tennessee continues to have pediatric behavioral health is a pretty significant quality aim for them. And in fact, as an aside, the agency is going through a reprocurement of its managed care contracts right now. And if you look through that, there's a clear emphasis not only on pediatric behavioral health and connecting it to physical health, but also on kind of the health equity issues that stem from a lack of good and true access to behavioral health for kids.
So, Gabe, to hear that the reauthorization of the reselection of the MCOs contains details about mental health is a testimony to you and your team in listening to providers, convening the MCOs, and really making it a priority. A lot of people, Lisa, you've said this many times, by the time a child gets to a hospital and they're in mental health crisis, we have already failed. So maybe I'm going to just throw out the concept to the group and see who wants to jump in. A lot of what we're talking about here needs to happen before a child gets to the hospital. And who are those partners and what should they look like? And, there are not enough child psychiatrists out there. I think the most recent stat I saw is that across the United States, there's 10 for every 100,000 children that's out there. and it's estimated we need 47 for every 100,000 that's out there. So we definitely have provider issues on the psychiatrist side, but there are other folks that need to get involved well before we get to the child psychiatrist. So I'll throw that out. Barry, Lisa, any thoughts?
Sure. Well, a couple of things, Don, that you'd brought up, and then Gabe had talked about a little bit too, is we've all deal with the daily type of impact of the behavioral health stressors that children go under. We see that in our emergency departments and our inpatient side, and just the havoc that reaches with families and communities. I think one of the things that was encouraging with our work with Gabe and TennCare over the past couple of years when we were engaging with that was having that discussion, and then having that recognition that whereas we are dealing with individual patients that arrive with that, our ability to impact on them ultimately will have to take a much broader view of that, which means that being able to form relationships both on the local government, state government, and national government level with the priorities to be able to incorporate into certain aspects of care or contracts is one of those ways that we will ultimately be able to bring resources, I think, closer to where that crisis is occurring. So whether it's at school, whether it's at home with a crisis intervention team, with that, whether it's encouraging through payment options, increased number of beds for behavioral health for those kids that need those kind of things. I think that kind of partnership and being able to have that kind of dialogue was not only encouraging, but also enables us to start to have a longer term impact.
Yeah, and I'll just chime in a little bit there too. I mean, you're spot on in the number of resources and the lack of resources available in all sectors to be able to really handle the overwhelming volume. And so, we knew what was happening a lot from an inpatient perspective, but, also equally as fascinating has been having conversations with our outpatient providers and pediatricians on just the sheer work volume within their offices related to behavioral health challenges with kids. And so, no more are kids in the office and you treat a ear infection or you treat strep throat or some diagnosis. You also have to be equipped to treat all of the dynamics that are in play within their social systems and what's happening with them mentally as well. And so, we've been able to get some great partners on board to bring behavioral health services into pediatric practices and to really have some conversations with providers on how to integrate behavioral health services into medical practices. And so we've done some training through the REACH Institute. The state of Tennessee has a great partnership with the American Academy of Pediatrics and the mental health department as well to really help integrate some of those services into clinic practices, which is vitally important. And then the last thing I'll mention is, obviously we've talked a lot about schools. Schools have to be at the table because, as Dr. Gilmore had talked about, for whatever reason, schools the stressor, definitely a defined stressor. And so making sure that schools are at the table and a part of the solutions is important also. But, I can't say enough for the community here in Northeast Tennessee, just the city and local governments, the police departments who have come on board and said, what do we need to know as we interact with you throughout this community to make sure we're addressing some of those needs as well. And so, we've been working on a child-friendly city initiative here that really does address just the overall holistic view of the child. If there are behavioral health problems or if there is domestic violence in a home, when you have law enforcement who respond, how are they helping to care for that child immediately? Because a lot of these things obviously are, adverse experiences that do affect the overall mental health of the child. And so there's not, to Gabe's point, there's not one silver bullet that you can tag onto or one solution. It has to be multifaceted with a lot of variables that come into play.
When I hear about all the different people involved in mental health, you mentioned firefighters, you mentioned police department, you mentioned schools, you mentioned social workers. There are a whole lot of people that are involved, pediatric practices. Gabe, from your perspective, as the head of a Medicaid organization, how difficult is it to get your head around all of that? Hospitals are really good at saying we had, this number of admissions and this is how long they stayed and what our length of stay was, and we need to reduce our length of stay. We're good at that. But when we start talking about this whole network of diverse folks that are out there, as a leader of a Medicaid organization, how do you get your head around that? And what are some first steps? Love to hear about your thought process.
Yeah, it's really challenging. It's interesting because I feel like most people now today, and I'm including myself in this, it's not difficult to figure out how all of these different diverse entities or groups of people or folks who stand in the shoes of providers from time to time impact the health and the well-being of children. That's not as hard. What's more difficult is from a regulatory and reimbursement standpoint, trying to track the dollars, the Medicaid dollars, the state and federal dollars. To your point, it's really easy to be able to do it to traditional primary care providers, community mental health centers, FQHCs, rural health clinics, and hospitals. That's just kind of blocking and tackling. But when you try to figure out what is the value to the health outcome and to the system as a whole, when you can keep families together, to Lisa's point, when you have potentially domestic violence or justice involved parents, the little bit of money that it would take from time to time and a lot of elbow grease and a lot of person-to-person interactions to be able to help get in the home, help understand how to de-escalate issues, how to be able to keep children in homes with their parents. When you have children who may be in school and are having issues, what's the root cause of those issues? How do we take that information and then put it in a feedback circle and go back to our policies and our reimbursements and trying to get upstream from those issues so that the children can stay in schools and so that you don't have to have sheriff's departments come out and respond to issues that they may not even be equipped to respond to. And how do you do all that? And it can get really challenging really fast. I think one of the things that I've been the beneficiary of when I was the Medicaid director in Tennessee is that I followed some really impressive predecessors and I had a really impressive team there. Understanding, number one, that while our office was in Nashville, if we made all of our health decisions and Medicaid policy in Nashville, and not respecting the rest of the state and not taking advantage of the differences across our state, we were going to set ourselves up for failure. And so we were able to get out and understand, to your point earlier, Don, what's happening. Because what's happening in Johnson City may be the exact same thing that's happening in Shelby County. But what also may be true is that how you address it in Shelby County could be completely different than how you address it in Johnson City. Two completely different regions of the state, frankly, two completely different regions of America. We used to always say that you were geographically closer to Canada when you were in Johnson City than you were to Memphis, and yet both areas were in the same state. So to answer your question, can be very complex. So the idea that people outside of traditional providers impact the health and the outcomes of children, not hard to capture. To understand how to be able to reward those individuals and make sure that they're compensated correctly so that your system hopefully doesn't have gaps in it. Or if there are gaps that can be mitigated quickly, very difficult. I think the most important thing I would say, kind of hopefully to wrap this long-winded answer up, is that the most important thing when you're thinking about policy is, number one, it's iterative. You're never going to get it right the first time, and it's always going to need to evolve. That's the first thing. The second thing is that both as you're drafting the policy initially and as you're trying to figure out how to make it evolve, you got to have providers at the table. You got to have the MCOs at the table if you're a managed care state. And you got to have the communities at the table. There's some really, I hate to single out parts of the state, but there's a really interesting thing that the health system of Ballad is involved with around this accountable care community issue. It's like an ACO-like system, but it's a lot of community-based organizations that are coming to the table to try to figure out how do we holistically address the needs of our community. And I'm sure there are things like that in Shelby County, in Chattanooga, et cetera, but it's really interesting. And I think that while it can be complex, if you get the right people at the table, you can kind of eat that elephant one bite at a time and start making iterative improvements.
Gabe, you talk about having providers at the table during, as people are writing policy. Barry, you're a physician, you're a pediatrician, you take care of kids every day. I know you've thought a lot about, policies and what we should be doing legislatively. Maybe give us a few thoughts on, building on Gabe's comment there. What are some things that have helped already, and what are some things that could be more helpful in the future?
Sure. I think, well, the first part of that, and is sometimes the one that's the hardest, is to get folks to sit down together across a fairly large spectrum and have a discussion about what the definitions are on some of these types of behavioral health issues. We found that out here in Tennessee, that we thought we were all talking about the same thing. And in fact, we were talking about something quite different, whether it came from coding, whether it was built on reimbursement, those types of things with it. Some of the discussions that also developed out of our interaction with everyone in the Children's Hospital Association of Tennessee, which is all of our children's hospitals across the state, was to have an open conversation about what it is that we do in each one of our areas, standardize a little bit of our reporting with that, and also start to recognize that that there may not be one solution that fits everybody's problem in their particular area, that hospitals, regions, and even states all approach something or approach a solution based on what their problem is at the time, what their resources are, and what they really feel like they could potentially accomplish with that. So several of the things that we've noticed and feel that could be beneficial across the board is that ability to acutely access rapid evaluation. Most of the interventions that are needed and most of the crises that occur usually can be addressed downstream as close to the problem as possible. So if it's at school, if it's at home, if it's at the doctor's office with that, before it escalates up with that to a different area. That evaluation, that ability to have a disposition and get access to a specialist if you need that for very specific kinds of treatments with that. Looking at the increased general population access to behavioral health, one of the things we recognize too, and I think most folks that are listening to this probably will recognize this too, is that a majority of children that come to an emergency department, they don't come to a pediatric hospital. They end up going to an adult hospital that has significantly fewer resources to take care of behavioral health issues with that. And so often get lost in that kind of shuffle because there are not those kind of resources, or get transferred to a children's hospital because there's not issues there. So that ability to tap into those resources downstream with that, so that you're not having to pool all those in one place is certainly something to consider with that too. I do think that one of the things that we have found exacerbated by the pandemic is the things that we've noticed, at least here in Tennessee, where we are bordered by a lot of different states and in different regions, is that the resources are significantly different in different parts of not only our state, but also in the region. But some of the regulations, some of the requirements, whether it's through your insurance, whether it's through regulatory needs on a state or federal level, often prohibit your ability to provide care to children with that at the best place. So I'm in Memphis, and it takes literally 10 minutes to be in another state with that, but I may not be able to access resources in those other states that are more appropriate for a child that we're seeing because of regulatory issues with that. Or, for example, I know Lisa has had this problem too with that, and Don, you have too, is we have children with very specialized behavioral health needs, or autistic children, for example, with behavioral needs. Trying to find a placement for a child who has significant behavioral problems and autism or autism spectrum disorder with that is a search through an entire region of the country in order to find an extremely limited resource. So that ability to look at those types of ways that we can incentivize folks and also break down some of those barriers where we can provide care not only within the state that we're in, but within the region that we're operating in, I think can make a significant difference for healthcare outcomes for some of our kids.
This issue about Medicaid and state lines has been going on for years. I was in Atlanta many years ago working at the Marcus Autism Center, and Gabe TennCare was always great to work with because they would let us take some of those severe behavior kids down in Atlanta and take care of it. What are some of the barriers, Gabe? Why don't people let people go outside of the state? What's the issue there? And in Lisa's thing, you said she was close to Canada, even leaving the country. Like, what are those barriers that Medicaid has?
Yeah, I mean, by design, Medicaid is a state-federal partnership, and every state's program is supposed to be different. There are clearly kind of minimum bars. You have to do X, Y, and Z. And for children, it's a pretty expansive benefit. But in terms of how the program is administered and designed and how the various providers are reimbursed, it really is a state-by-state issue. I mean, I think it's probably rooted in federalism from a constitutional perspective, where the state is funding a significant portion of the budget. And as a result of that, they have some responsibility and accountability, but also kind of the benefit of being able to design their program for their population. As is, I think, probably true with most generalities, though, there always is room for exceptions. And when you look at Tennessee, which is a state that is 100% managed care, and you look at all of the requirements and all of the things that we as a state and as an institution and system have learned in terms of what's required to have a, quote, adequate network for all of the folks who are taken care of by the Medicaid system, we've done a lot. And there are just some realities on the ground that require MCOs to be able to look out of state. There may not be enough providers, or there may not be a provider of a specific type that might be needed from time to time. And so those, not only are the managed care organizations allowed to, but they're required to go out of state to try to find some of those resources. I think that at the end of the day, one of the trends we may see is exactly this idea of potential regionalization around specific populations and specific issues. As our system is learning, we talk about ACEs and we talk about trauma-informed care being really specific. I think we're also realizing, to Dr. Gilmore's point, there's also condition-informed care that need to happen in certain instances. And that can be really specialized and really difficult to get. Doesn't mean it's not important. And so one of the interesting things I think are to watch over the next 5 years or so is to see in those instances, whether it is a specific BH need for specific individuals with intellectual developmental disabilities, or whether it is some specific need for children on the autism spectrum disorder, something like that. Are we going to look at more of a regional approach and get away from kind of the single case agreements from time to time with a Texas provider or an Atlanta provider to be able to say we've met network adequacy requirements? If so, I think that's going to be an initiative led by the states. I think the managed care organizations do a great job of being able to look across their kind of, statewide, nationwide provider resources to be able to help folks out. But I really think it's going to take some thought leadership and some innovation with some states working with their federal counterparts to figure that out, to make it work correctly. There are some issues around licensure and a bunch of regulatory issues, either CON or licensure for providers, that also are state-based, that further kind of complicate the issue some. But a couple of kind of examples or silver linings perhaps from this terrible pandemic that we're seeing is that with the stroke of a pen from a regulator, you can at time waive some of those things. And so you can say, hey, we may have some excess capacity from providers in Kentucky or Mississippi or Arkansas, and we can use those folks through technology, telehealth, to be able to backfill some of our need. So perhaps we can take some of that in-person resource and repurpose it to try to really hit the need of folks that are really impacted here on the ground. That's one very insufficient example or analog, but I think that's really interesting. And I think when we get kind of through the pandemic, or at least the immediate needs of that, I think one of the questions that Medicaid is going to have, Don, is exactly what you're asking: is can we get past? We don't want to get away from the intentionality of the differences from state to state in Medicaid, because that's important for a number of reasons that we don't need to get into now. but can we also get away from that as kind of the general rule on specific issues and get to more of a regional approach to ensure that we have access to services, not just in form and on paper, but in substance, and really be able to drive better outcomes for folks, even if they happen to live in different states from where the resourcing need is.
Gabe, it's so exciting to hear from a commissioner of Medicaid your detailed understanding of what the barriers are and the issues. Lisa, I'm going to ask you to speak for a second on chat. And the reason is I think part of the key to success, the successes that we did make in Tennessee, were that we had this organization that was able to convene all the pediatric providers together, and you were willing to engage with us, as opposed to having different groups come at you from every different direction. Lisa, describe a little bit about chat, and then I want you to also talk a little bit about the schools and what some of that data talked about with correlating when kids were in schools, to kind of move that conversation along.
Sure, and yeah, we still miss Gabe. I mean, we have great leadership in Tim Care today, but Gabe was always more than willing to come to the table and really listen to the challenges that we had as children's hospitals. And so the Children's Hospital Alliance of Tennessee is made up of the 5 children's hospitals located all throughout the state. Again, you've got representation here from Johnson City to Memphis, even today. And so we do have one freestanding children's hospital that's a part of it. And so having that voice and being able to have those leaders and people throughout the hospital come together collectively to talk about some of these things have been vitally important in our ability to tackle some of it. We also have a very robust quality collaborative within the children's hospitals, and that piece specifically has made the difference because, to Dr. Gingler's point earlier, we came together and said, what is a behavioral health admission? What does that look like? And so we came up with some common things that we wanted to track all throughout the state and are still tracking some of it with the help of THA and the Tennessee Hospital Association. So we knew the number of hours that we were using for sitters. We knew some of those costs and some of the things that we were faced against. And so we really took it on from a quality perspective. The other thing that we talked about was team member injuries. And, we mentioned that with some of the aggressive behaviors. And so we wanted to see who had best practices in preventing some of those injuries of occurring in our hospitals. And so through that hospital alliance, we were able to come together collectively and have those conversations. So it's so valuable. I mean, very valuable dialogue that we were able to have. And then, like I said, able to take that back and still are having conversations with Tim Care, the Department of Mental Health, the Department of Education on what we're specifically seeing. And so, one of the things I'm glad Gabe mentioned the telehealth, because again, of anything that's a potential positive in the pandemic, it has been related to telehealth and how we've been able to expand those services. And so one of the things that we are currently piloting here within one of our school systems is a Telesolution for behavioral health. And so, recognizing, as we've talked about already, resources are limited. And so how can we use teleconnections within schools to have some of those counseling visits? And oftentimes it's just a medication check-in. Do you have medications available? Do you need a refill on prescription? And so we've partnered with one of our local behavioral health providers in the region to offer teleservices to one of the school systems. And so hopefully we can continue to see positive benefit from that and expand it into even more schools throughout the region, because it's been a tremendous benefit. And again, as you mentioned earlier, recognizing that if a child lands in that emergency department, it is a failure on the system. And so how are teachers and people who interact with children every single day educated on recognizing some of those warning signs? And so that was also important, an important aspect of the telemedicine, because as we're engaging with that student in the school, we can also engage with the teachers and people there to educate them on some potential failures within that student and some warning signs they need to be aware of. And so again, really trying to create a holistic approach to what we're doing and bringing as many people as possible to the table in the care of that child and that family.
So Lisa, I remember, I'm going to go back in time to some of those early chat meetings where we sat around and we gathered data, and Gabe came to the table with his MCOs and we said, well, this is what we're seeing. They said, we're not seeing this. So we got our data together. We all sat down and started looking at it. We saw this correlation between when kids were in school and suicide attempts. And it was crystal clear. And Barry, you touched on this earlier. I'd love to hear your comments now. Pre-pandemic, we thought the problem was the schools. The pandemic hit, and the first reaction I had was maybe we're going to see it go down. Maybe we're not going to see the suicidal ideation anymore because kids aren't in school as much. Maybe this is going to be really interesting. What are you seeing, Barry, in the data and in the hospitals? With kids not being in school, did we actually see things go down or did they go up?
No, I think during the first probably 6 to 8 months of the pandemic, we had a general decrease because no one came to the emergency department, or nobody came to the children's hospitals for sure. With that, I don't think that the problems were not occurring with that. They just weren't, unless they were critical in nature, they simply didn't show up at the hospital with that. What we've come to realize is basically that has just built up over the last almost 2 years now with that. And so we've seen this increase of almost 30% with that, 25% altogether on kids with that. But we see that for us on a daily basis of the number of kids that were coming in. And whether or not you are doing home remote learning or whether you are now back in school with that, I think we're seeing that increase in stress. What we really have noticed, though, is the longer that children were out of a learning environment where they were with other children and they were with teachers and professionals that could recognize their emotional problems that were developing, the more critical these issues became with that. And so there was no buffer and no ability to intervene or even have conversations or support. So as stressful as school is to certainly our teenagers at times with that, it is also a place of remarkable support, whether it's through their friends, their teachers, their counselors, their sports, their other activities with that. It provides a tremendous amount of support to them with that. And that simply has been gone for the last 24 months.
It's very interesting to hear you talk about teachers being the front line of defense, to talk about screening and evaluation. I think it's true that they're not healthcare providers, but they're the ones that are recognizing the problems first. And without them in the game, it makes it really hard. People always say, don't let a good crisis go to waste. Gabe, to your point earlier, the speed at which the administration released all the restrictions on telemedicine was absolutely amazing. And, to Lisa's point earlier, it's part of the solution going forward. I want each of you to answer this question. Health Connect South has close to 1,000 people that participate on a regular basis. So we could potentially have 1,000 people watching this conversation we're having about pediatric mental health. We talk about resources as a main issue. We talk about not having enough providers. We're talking about having folks in schools and the police department and all these different agencies that are involved. There's got to be somebody listening today who's got a solution in mind. What solutions do you think could be out there? Maybe they're not even healthcare solutions. Maybe they're IT solutions. What are the types of solutions that we should be thinking about that we could leverage going forward with such a diverse group that Health Connect South has pulled together? I mean, you've got IT people, you've got philanthropists, you've got drug manufacturers, you've got all sorts of app builders. I mean, this is a very eclectic group of people that are getting together. And my hope is that after our call, after our video, somebody's going to reach out and say, hey, I've got a solution. What are those potential solutions you see on the forefront? Gabe, maybe I'll start with you.
It's a really good question, and could go in a bunch of different ways. Some of the work that I do now is in the private investment space. And I have for a long time been an advocate of the private investors, private equity, venture capital, making sure they are focusing on the Medicaid population. It's difficult at times because it's different. It's cradle to grave. There's a lot of differences in this population and can be, but it's also really important. And I've been really encouraged over the last 2 to 3 years, and this has happened before then, but this is when I've really been paying attention, at the amount of innovation that is trying to get into that space. And I think that while it may not necessarily be easy, and it certainly isn't, hey, this solution worked on the commercial side, or this solution worked for self-insured employers, or it worked for Medicare, so it should easily work in Medicaid. Well, it's not going to be like that. I do think that there are some really interesting opportunities to go and do exactly what we've been talking about: resource allocation, optimizing the ability to take providers from one area to another, whether that's through technology or otherwise. Logistics, I think that's also something that's really interesting that's out there. I think schools are extremely undervalued in terms of what role they play in the healthcare system, from being able to be an opportunity for healthy food for children, to the point of being on the front lines, and oftentimes there when there may be behavioral health exacerbations that are happening and causing disruptions in the schools. And I think they are extremely good potential partners and better partners in the future for the healthcare system. I think they can be extensions of the children's hospitals and the specialty providers that are in communities. In terms of actual things that I've seen that I'm interested in, and this may kind of sound a little bit weird, right? But I think virtual reality could be a real interesting thing moving forward. We talked about telehealth. We all know that kind of toothpaste, thankfully, is out of the tube and it's not going to go back in. But if you think about the advent of 5G as potentially being something that allows us to overcome some of the infrastructure issues in rural areas, and you think about the impact of virtual reality, I think that could be something that could be really interesting and fascinating. I think it solves a lot of the problems. I think you've got healthcare provider. You can have a healthcare provider with an avatar talking to a child or talking to an adult, right? I think you can go everything from education and learning, pre and post-op, to physical therapy, to potentially treating folks, doing counseling and other things that they may need on an ongoing basis. So I think that's really interesting that I've seen, that I really think that there could be some potential there. We're probably still several years away from that, but I think that's a pretty fascinating and cost-effective issue. The other thing, and I'll kind of step out, as the former regulator, I think that you're starting to get more and more innovators' mindsets in the regulators. So from a system standpoint, what Dr. Gilmore and what Lisa have been talking about, I think there's going to be less likelihood that the regulators immediately say no and then ask you to convince me, and instead say, that's interesting, let's talk. Or maybe even better, we have an issue, we don't know how to solve it, can you come give us some ideas? And I think that probably is the most readily apparent near-term reason that I'm excited, because I think that's going to end up being able to actually get the ideas from the providers, from the payers, and get those to explode and kind of throw kerosene on that fire.
Dave, thank you so much. Dr. Gilmore?
Well, I think there's a range of things that we can be looking for, but for the folks on this particular call, and then in the audience with that, one of the things to try and encourage and emphasize is that that ability to have a conversation with your community resources and individuals can really make a difference as far as how you address an issue that is critical in your area, but also can be escalated to a regional and state level, like we had talked about. The solution doesn't need to be the same, but the discussion is what's key about that. That ability to get in the same room together at times, on a video chat, and say, these are the particular issues that we're dealing with. And if you're willing to work back to where the basics are with that, you can put together resources and options, if folks are willing to do that, that can start to address your needs. Won't solve the problem, but it certainly starts to address those issues.
Lisa, you're going to get the final word.
So I'll just finish with, I mentioned our child-friendly city initiative, and one of the best things that we did was we sat down with kids. And so I would encourage everyone to just sit down with kids and have conversations with them. Get them to the table, help them be a part of the solution, because we were fascinated by what we learned. And when we gave some of the ownership over to those students and those teenagers that were involved, it was amazing. And you think about how much these kids know and how much information they have and what they can do. They can have solutions that none of us would ever think of. So I encourage you to have conversations with kids.
Great, great, great thought. So I want to close with just remembering what we're talking about here. We're talking about mental health care. We're talking about kids with mental health care issues. Second leading cause of death for folks 10 to 24 years of age. All right. This is serious. I remember when we looked at the chat data, we saw children 10 years old committing suicide. This is a very serious topic. I love the thoughts. I love the conversation today. I think a lot of it is about communication. It goes back to who do you communicate with? How do you communicate with the kids? Use the technology, get the people in the community involved, get the primary pediatricians involved. None of us have the solution, but we do have solutions we're all working towards. So with that, I want to thank everybody for spending so much time with us. And I think we would open it up to any questions via the chat box.